Another problem we have is medicine has improved, but side effects from the new treatments have improved or revealed themselves more often than we would expect. Biologics were developed at Mount Sinai, where I teach up the block. We have great results from treating inflammatory skin disease like psoriasis, rosacea, with the biologic treatments. The only problem is because it alters the cell biology, sometimes people develop cancers. This patient has an obvious lump. This is in the neck area. You can see it on the sonogram, but the sides are not regular, even though the margins are pretty well outlined. And one thing I didn't realize when I did this picture was there's a big, big blood vessel with the red arrows down there. When we put on the Doppler sonogram, you see this blood vessel is the main aortic blood vessel. And this so-called fatty tumor is being fed by a large artery. If you put a needle into this to biopsy it, you will get blood in the biopsy and blood all over the floor. We were able to find the nature of the lesion, that it was not a fatty benign tumor, and the patient with lymphoma was treated accordingly with radiation and now with the new immuno-oncologies. Cutaneous lymphoma, this was sent to me from my colleagues in Europe. The skin disease, the skin cancer, shows up as dark areas. This is the white area, is the normal dermis, and the tumor is darker. The white line here is the border of the tumor, so it's not breaking through the skin. And this is the 3D Doppler. So this is used worldwide. A post-op lymphocyte. So you cut something out, you treated it. Is it a recurrence of the cancer? Or is it on the MRI just a simple fluid-filled cyst? But see, the cyst is connected to a big artery, so be careful where to put the needle in to drain the cyst. If you put the needle in here to drain it, you get hemorrhage, because this is a branch of the brachial artery. We use imaging before we treat. And hopefully we use imaging before we biopsy, especially with skin cancer. The second you biopsy something, you get healing scar tissue, which can affect the imaging we do later with all our new skin cancer imaging technology. So it's best to get something scanned before you put a needle into it or biopsy it. This is post-op. Is it a tumor recurrence? Scar here, lump there. The sonogram in both cases shows it is not a tumor recurrence. This is the white skin. You have a dark area because this is the suture which formed the granuloma, or a infected area. It's like a slow-growing infection. Fortunately, this is benign. On the other side, the fat necrosis, which is dead tissue from the treatment, heals by scar, and the scars calcify very often. This is why if you feel something hard under the skin, it could be a tumor, it could be calcium. It's important to know that calcium rims are benign, but if you put a needle into this, the needle could break. And there's a needle floating around the tissues now, in addition to the calcific mass. So look, scan before you put needles in. This is the squamous cell skin cancer, which is fairly aggressive. These things can metastasize throughout the entire body and go to the breast. There's an entire field of histology, cancer histology, called basosquamous breast cancer, because the skin cancers in this type commonly spread to the breast tissue. Anyway, here's the tumor on the skin. This is the tumor depth. To see the resolution we have, this is a vein, and these are the valves, the two valves inside that open and close the vein. So we have superb technology and imaging. Also, is it a tumor occurrence or something else? The summertime is coming. People will get splinters. The white area is the skin. You see the straight line of the wooden fiber, and the dark is the inflammatory response around it. And this is the pathologic specimen. You can't see this. It's under the skin. And the depth under the skin was from 1 millimeter to 2.6, and the length was 15 millimeters on this. People don't forget that, or people don't remember if they're at a cocktail party and step on something, and a week later they've got something in their foot, or they brushed against something in their arm and they develop a lump. We have to look before we diagnose and before we biopsy. This is a cautionary note, because hair, when you treat hair, there are cysts of the hair and a lot of benign tumors related to the hair follicle. This patient was treated with PRP to grow hair, developed this lump. We always feel the lump for pulsation. We put the stethoscope on to hear for sounds, if there's any blood flow. If the top of the lump or the aneurysm or the big area of blood flow is filled with healed tissue or thrombus, the healed clot, if you will, you can't feel the pulsation and you can't hear anything. Again, you put a needle into a vascular area, it's going to bleed. So in this case, the needle biopsy was canceled. Going back to the blood flow, let me remind you, this is Doppler technology. It's quick, it's painless, and it's accurate. We scan an entire area in seconds instead of, say, an MRI, which would be half an hour to an hour with an injection. You have a mass under the arm. The probe goes over the entire mass. We press a button and it takes hundreds of pictures in seconds, 200 to 300 pictures in 10 to 20 seconds. And you get pictures like this with the blood flow technology. Important, where do you biopsy? First of all, you know it needs to be biopsied. If you put the needle into the bottom part, which has basically no blood flow, you will get dead tissue and a very unhappy pathologist. If you put the biopsy needle into this area where there is active cancer tissue, where the vessel density is 27%, you will get a correct diagnosis. I go to all the world conferences, and this one was done in in France, 2018, where the ICIS, that's the International Cancer Imaging Society, puts all their work in. And we presented pitfalls in CT and MRI, which are, again, resolved by using better technologies. So now the MRI has diffusion technology, which means you look at tumor hardness. So cancer is hard, benign fatty tumors are generally soft. The MRI has a technology that measures the hardness. Ultrasound does the same thing too. We all have technologies now that look at the hardness, but that's part of the next part of this lecture, the measuring hardness. And the doctor at MD Anderson said, because we use the new MRI technologies, we can avoid using contrast in CT, in other words, dye for CAT scans and dye for MRIs, which may have side effects. Moving on to other uses. I was talking to the US Olympic coach for the boxing team, and he was explaining to me, how do you look into the eye if a boxer's been hit in the eye? You don't know what's going on because the eye's filled with blood. Well, guess what? The ultrasound goes right through the eye. It sees through the blood, which you can't see through with a slit lamp or any of the visual optics. And not only do we have blood, but this patient had a cancer. It's a choroidal melanoma, very, very deadly. And the MRI failed because you really can't see much. The blood and MRI technologies don't show the active tumor blood flow. Back to scarring. Skin is white. Scar is dark. We have technologies that show the scar depth. The scar's treatment is successful, but isn't it better to know how deep the scar is before you're sticking cortisone in the surface when the scar is much deeper? Because we have ultrasound hardness treatment, it's called elastogram. We measure the scar. So the scar, well, here's the scar in regular ultrasound, this area. And it's almost 4 millimeters thick, the scar. And the scar hardness shows up blue, so we have a way of measuring it. Tumors that are not hard, that are fatty, are green, soft. Also, there's new electrical current therapy. There are many new electromagnetic treatments for scars and other things that are being used in sports now, like pulse electromagnetic treatments and near-infrared treatments. And there are many options now that weren't available with treatments.